Hope S. Rugo MD of City of Hope with the latest updates from MOASC. ADCs and oral SERDs are transforming breast cancer care right now. DESTINY-Breast09 delivers 40.7-month median PFS with first-line T-DXd plus trastuzumab. New maintenance strategies now extend responses beyond 2 years. T-DXd boosts PCR and IDFS in early high-risk HER2-positive disease. TROP2 ADCs reshape first-line TNBC while proving sequencing matters. This and more in 3, 2, 1. How has the DESTINY-Breast09 data changed your first-line treatment approach for patients with HER2-positive metastatic breast cancer?
So DESTINY-Breast09 that evaluated trastuzumab deruxtecan alone or with pertuzumab and compared it to a Cleopatra regimen of THP, I think is quite practice-changing, but it's not for everybody. And I think the way we think about using a maintenance type strategy will be really important as we utilize the DESTINY-Breast09 type approach in treating patients with metastatic HER2 positive disease. So we don't know what T-DXd alone does yet because that arm hasn't been reported, but T-DXd and pertuzumab really markedly improved progression-free survival. And, you know, it's interesting looking at those patients, we could further improve progression-free survival because although you could start endocrine therapy, not a lot of people did in either of the arms. I think people need to remember to use endocrine therapy. We've seen that across a number of different trials in ER-positive disease. And, you know, that will help things even further. And then patients who were having toxicity, you know, had to stop T-DXd for either pneumonitis or were having toxicity, they could actually go on to add trastuzumab to the pertuzumab as a maintenance type approach. And we still saw these very good results. Now it was a small number of patients. So how do we take that data and put it into clinical practice? We don't have the survival endpoint yet. And it has been interesting because a lot of people are still on first-line therapy. We don't really know how many patients will receive an appropriate ADC as their next second or third-line treatment. T-DXd improves survival in that setting, so we're hopeful that we see that. But, you know, T-DXd is not available to everybody around the world, so we'll have to see. So what should we do? Well, we have the results of PATINA that show this remarkable improvement in progression-free survival with a maintenance approach using the CDK4/6 inhibitor palbociclib in hormone receptor-positive disease along with HP. This is a strategy we've employed. We give hormone therapy in HP, even though a lot of people didn't in DB09, including HER2-CLIMB05. But when you add in palbociclib, you really dramatically improve the PFS. And this was an investigator-initiated alliance foundation trial, and it still led to regulatory approval because the difference was so remarkable and the treatment is so tolerable. So when we think about using T-DXd, I think the question comes up whether or not you might just treat to best possible response. You know, have a really great partial response, complete response, and then go to this maintenance strategy, particularly for ER-positive disease, using a PATINA-like approach. And the prospective single-arm trial, DB-GUIDE, will actually look exactly at this question and gives us some data about how long patients can stay on treatment. ER-negative disease, we hope to see approval of the tucatinib-HP combination approach used in HER2-CLIMB05 that also improved PFS, and that could be employed potentially in ER-negative disease in a way to prolong the progression-free survival. You know, in Cleopatra, looking at THP, adding P to H, we saw that a percentage of patients were still alive without progression at 8 years of follow-up, the last reported follow-up from Cleopatra. I believe that using T-DXd as an induction will actually increase the number of people who can potentially be cured of metastatic HER2-positive disease. So I think this is a huge advance. Now, most of who we're going to treat in the metastatic setting is going to have de novo disease moving forward because early stage disease, we've moved T-DXd into that early stage setting. We're going to cure more patients of early stage, even poorly responsive disease. So this is going to be an approach mainly for patients who've never had treatment.
What role do you see for maintenance therapies such as palbociclib or tucatinib after induction treatment in HER2-positive metastatic disease?
So maintenance therapy after induction in HER2-positive metastatic disease in the first-line setting has been a mainstay of the treatment for patients with metastatic HER2-positive disease. And we like to have that time on maintenance therapy, which is almost always better tolerated than the chemo approach or the ADC approach, be as long as possible. And occasionally we see people just stay on that therapy and never have disease progression. And we're faced with the question of when to stop all treatment because the cancer is clearly gone. A question which is being answered in a number of different trials now. How long should you treat when you're giving maintenance therapy and a patient has no disease? We often use 10 years, but maybe shorter is okay. So we'll get the answers to those questions. So the PATINA trial was a remarkable trial that showed that the addition of palbociclib to endocrine therapy and HP in patients with responding disease who finished their Cleopatra induction with THP, or they could have gotten vinorelbine, but very few did, dramatically improved progression-free survival. So it quickly became a standard even before we had the recent, almost unheralded regulatory approval from this trial, which was a Alliance Foundation investigator-initiated study. So very exciting that we can now use this with regulatory approval, although it was already listed in our guidelines before. The tucatinib trial is a newer trial. There's clearly more toxicity with tucatinib than with palbociclib. So I think that we would use that in the ER-negative setting. So ER-negative HER2-positive disease as maintenance and add it to HP with a low threshold for dose reduction if patients have toxicities, which mainly are diarrhea and liver enzyme elevations with tucatinib. So I think both of these are remarkable advances, and they do make us think about how we should do induction. So should everybody get T-DXd, or could you give some patients THP? And I think with minimal metastatic disease, low disease burden, ER-negative, highly responsive disease, THP may be a reasonable approach for these patients, and you could wait on your T-DXd to the second line. But for most patients who have visceral metastases and more aggressive disease, I think the T-DXd up front, followed by maintenance, gives us our best ability to control also the subsequent risk of brain metastases, which is such a critical issue for our patients with HER2-positive disease, where often disease is progressing in brain only. Both T-DXd and tucatinib have impact on brain metastases, and we're very hopeful that giving an induction with T-DXd and the right maintenance, even palbociclib showed delayed time to brain metastases, although they weren't tracking for that. It's still intriguing. So this approach may not only keep patients with disease control for longer, but delay or prevent brain metastases.
How are you incorporating neoadjuvant or post-neoadjuvant T-DXd into the treatment of high-risk early HER2-positive breast cancer?
So we saw quite recently the results from DESTINY-Breast11 and DESTINY-Breast05 that used trastuzumab deruxtecan as part of the neoadjuvant or post-neoadjuvant treatment for HER2-positive breast cancer. DESTINY-Breast11 looked at a sequence approach with T-DXd followed by THP versus an AC-THP approach. The third arm that looked at just T-DXd for 8 cycles wasn't better, certainly, than AC-THP. And in fact, in the initial results looked inferior because a lot of patients dropped off and were termed non-PCR because they dropped off. But it looks fairly equivalent when you censor those patients. So T-DXd followed by THP markedly improved the pathologic complete response rate compared to AC-THP. And I think overall it's nice to avoid the AC. But we expect that AC-THP is equivalent to TCHP that's used much more frequently as part of our standard regimen for early stage HER2-positive disease now. You lose the carboplatin, which is great, so you don't have quite as much nausea from the carboplatin, which might be harder to manage than the nausea from T-DXd. But you also don't have the thrombocytopenia, which can be problematic with carboplatin, and it's a stem cell toxin. So for our younger patients, it causes a higher rate of infertility or ovarian failure, which is an adverse outcome for many of these patients who still want to maintain their fertility. So regardless of how you think about it, T-DXd followed by THP was superior based on pathologic complete response. The rate of interstitial lung disease was the lowest reported for any trial with T-DXd at just under 5%. And the one death that was reported in each arm was during the THP. We don't really understand those deaths and need to think about that in more detail and understand more about what happened to those patients, because they were classified as ILD, but we don't generally see ILD with THP, so it's a little bit unclear what happened, and it was equal in both arms. The question really comes up, what happens to those patients over time? Does that PCR translate into improved event-free survival, which we assume it does? The trial wasn't powered at just over 300 patients in each arm to look at event-free survival. So then we had the DB05 present at the same time. DB05 looked at the Catherine regimen that's shown improved event-free and overall survival in patients with residual disease after neoadjuvant HER2 targeted therapy with chemotherapy, and those patients who got 14 cycles of T-DM1 versus primarily trastuzumab alone had improved outcome, including overall survival with longer follow-up. So in this study, T-DXd was compared head-to-head with T-DM1 for 14 cycles. ILD rate a little higher, 9.6%, a couple of deaths from ILD at 0.5%. We clearly need to be monitoring and managing this the best we can. But at a much earlier time point than Catherine, the trial showed a remarkable and significant improvement of almost 9% in invasive disease-free survival with 14 cycles of T-DXd compared to 14 cycles of T-DM1. So what do we do with that data? We've got two trials. One, you gave 4 doses of T-DXd with THP. One, you gave 14 cycles, but you're targeting the population who have residual disease. So one of the questions that's come up is what to do, particularly because that 8 cycles of T-DXd wasn't any better. So if your cancer is not gone away early, giving more of the same drug doesn't seem to help the outcome. How could we employ this in clinical practice? I think for smaller tumors, tumors that are very likely to respond to HER2 3+ by IHC and highly proliferative ER-negative tumors, THP alone may be sufficient for many of those patients. And as listed in the NCCN guidelines, you can give THP first and T-DXd after that. So you could say, oh, you've had a great response, but it's not all gone, so let's give you 4 cycles of T-DXd before surgery. And I like that approach for patients with residual disease. And then I would use the DB11 approach for a patient who has really a lot of cancer, inflammatory cancer, et cetera, where you need that response to be able to go to surgery. What about using DB05? Patients with residual disease who haven't received T-DXd or just got 4 cycles with an excellent response, I would use the DB05 approach, and it will remain to be seen with real-world data whether or not giving T-DM1 is still effective after T-DXd in patients with residual disease that didn't respond to T-DXd. I think in those patients we're going to need an alternative approach, potentially these newer antibodies, the biparatopic antibodies, zanidatamab, for example, different ADC might be, even immunotherapy might be appropriate rescue strategies in that setting.
How has the ASCENT-04 trial influenced your first-line choices for patients with PD-L1 positive metastatic triple-negative breast cancer?
So ASCENT-04 is a trial that evaluated trastuzumab govitecan, the TROP2 antibody-drug conjugate, the first one approved for triple-negative breast cancer, showing an improvement in progression-free and overall survival in the pretreated metastatic setting with pembrolizumab to the KEYNOTE-355 regimen in patients with PD-L1 positive untreated metastatic TNBC, who, with, of course, PD-L1 positivity being defined as a CPS combined positive score of 10 or more. And the head-to-head comparison was really to see whether or not we could improve on that chemo pembrolizumab effect, which showed that adding pembro in that setting improved both progression-free and overall survival. Using the KEYNOTE-355 as a background and the control arm, they gave the same chemotherapy as in KEYNOTE-355, a taxane or gemcitabine and carboplatin, and the division was about half and half between that choice. Patients were eligible who had recurred at least 6 months or more after their last treatment with curative intent, exactly the same as the criteria for KEYNOTE-355, and the number was capped at 20% for those early relapsing patients in the 6 to 12 month range. what we saw was really interesting, a marked improvement in progression-free survival, statistically significant in patients receiving SG with Pembro versus the standard chemo plus Pembro. So a big advance for our patients. And we also, what was important in the trial design was that patients with a blinded independent central review confirmed progression could actually cross over and receive free trastuzumab govitecan without pembrolizumab, of course, because they already received Pembro in the first-line setting. And about more than 80% of patients, about 81% of patients who went on to next-line setting received SG. So the survival data is still quite early, but we wonder about the sequencing and whether or not that will impact our ability to see a survival advantage from this approach. But the PFS is quite striking. PFS2 is also longer, which, although not statistically valid, is a real-world endpoint, and that's important. And then there was no new toxicity. So giving SG with immunotherapy didn't increase immune toxicities, same usual toxicities from SG with neutropenia and diarrhea that we've learned how to manage over time. So this has really become the standard of care in the first-line setting for patients with PD-L1 positive metastatic triple-negative breast cancer who've relapsed after receiving early stage therapy or with de novo disease. And regarding that 0 to 6 months, I'm not clear that that really matters. I don't know that the outcome is different for patients who relapse at 4 months versus 7 months. So I would use this strategy for patients who are relapsing early as well. And we have a trial with datopotamab deruxtecan and durvalumab versus the standard approach in the PD-L1 positive patient population with Keynote 355. And then one arm is just looking at Durva alone to see whether or not it's just the ADC and didn't, need the immunotherapy. I am biased to think not, but we'll see what happens. And that trial will include the earlier relapsing patients. So we don't have results, of course, from that study yet. So that's for the future. But I think this is a very important advance for our patients.
How are you using ctDNA monitoring for ESR1 mutations based on the SERENA-6 results in hormone receptor-positive metastatic breast cancer?
So SERENA-6 looked at serial ctDNA in patients who'd been on their first-line endocrine therapy for metastatic hormone receptor-positive HER2-negative disease. They had to be 6 months on their AI plus CDK4/6 inhibitor without evidence of progression. But sort of the middle of the road of when, in terms of numbers of patients, when did they sign on for the study? It was around 18 months. So you could sign on at any time after 6 months, as long as you didn't have disease progression. And patients who had emerging ESR1 mutation, half of them at around 18 months when they first entered the study, and then a median time to ESR1 mutations showing up in patients who didn't have progression was at about just under 2 years of therapy. Those patients were randomized to either continue their endocrine therapy or switch to the oral SERD camizestrant. And they showed an improvement in progression-free survival with camizestrant versus staying on the same therapy, not surprising. Although patients who were on the AI and CDK4/6 inhibitor stayed on for 9 more months, which was kind of surprising. Same CDK4/6 inhibitor, so no switch, which is what we would do now. We also saw delayed time to deterioration in global health status, quality of life, and in pain, which I think is important. And then lots of other endpoints have been evaluated, but I think one striking one is the ctDNA, which dramatically decreased with change, whereas, of course, as you would expect, it gradually increased on the AI control arm. Looking at PFS2 is a little bit more difficult because very few patients received an oral SERD, even though they had an ESR1 mutation, once they developed progressive disease, because either they weren't available to them wherever they lived or they went on to other therapy. So what are we going to do with this data? It's not yet approved in the US, although it's approved now recently in Europe, but we expect it will be approved in the US with the additional ctDNA data and PFS2, although the FDA doesn't like PFS2, it's not statistically valid. So I think that what we would do is keep in mind that quality of life data. If a patient has pain and they're not feeling well, I'd screen for an ESR1 mutation and switch, even without disease progression. Patients feeling great, not really clear to me that I should be switching when an ESR1 mutation arises, but maybe I'm going to follow them a little bit more closely. And we have a trial which is starting this fall in France as a collaboration between the Alliance Foundation and Unicancer that will look at ctDNA as a marker. So not ESR1 mutation, but the total ctDNA. And in that, we'll be able to say, look, if you have a rising ctDNA past a certain threshold, you should switch therapy because your cancer is going to progress soon, versus patients who don't have a rising ctDNA. And in those patients with a rising ctDNA, we'll switch or not. And then we've built a crossover into that trial called Taylor Switch. Second objection of that, the second objective of that study, I think is really cool because we just get scans every 3 to 4 months. Patients say, should I get the scan on this date? Is it this time? Why am I getting the scan? So many scans. Is it safe? And we don't really know when to get a scan. You know, some people use tumor markers, but they're not all that helpful either. So what we're going to look at as a secondary objective is whether or not you could base your scans on rising ctDNA, which might help for many patients avoid numerous scans and cost of the treatment in the metastatic setting. So I think this is a really important advance. I think we're going to have to see when we have it in our hands how we can best deploy it in our patients, because I don't think all patients should be changed. But I think that we will selectively utilize this strategy to improve outcome for our patients.
If you like this video, take a look at the web post companion on oncologytube.com, which includes more detailed information. Thank you for watching.